just this weekend, I had a house full of 18-year-old girls, and the conversation of birth control came up. Now, it was not for birth control, it's for their hormones, it's for their heavy periods and the painful menstruation and all of the symptoms. It wasn't about, boyfriends and all of that stuff. Anyways, I said, well, did your doctor, I'm happy to look at your blood tests for you. And they said, well, I didn't get a blood test. I said, your doctor put you on a prescription and did not take a single blood test? No. She just said, I know what you're going through. This is the one I'm going to put you on. I put my daughter on it. And I was ready to blow my mind because, as you said, we are so complicated. And with hormones, you have just a little too much estrogen or a little too much testosterone or progesterone. It throws everything out of balance. And if you don't know what your, how do I say it? Taking care of the sleep and the stress and the liver health and all of these other things to get your baseline, so where maybe you do need the right level of hormones. You might be over giving a hormone, you might be under giving, you might not be doing the right amount. And when I got my blood test and my liver enzymes were through the roof, guess what else looked horrible? My cortisol was way up. My reverse T3 was way up. My testosterone was way down. My testosterone's always been good. So my point is that just because my body was over here fighting viral activity and my liver was suffering, it had this cascade of issues and effects on all of my other hormones. My blood sugar was through the roof and I hadn't changed anything. When what's so crazy is now my blood sugar, it's totally fine. I haven't changed what I'm eating. I was eating the same things back then, but that's how all of these other factors could be playing around with your hormones. And I heard you say something about it's not just the hormones you're getting or you're taking in, but it's your receptor sites able to actually use them or being resistant to them and losing just like you become insulin resistant, can you become resistant to some of these female hormones?
Well, it's you can have malfunction of any receptor. That is absolutely true. And we know that if you are on, and this is why I speak against this all the time, if you are put on as a menopausal woman, static low dose hormones, okay? So, and what does that mean? You get a small dose of estradiol, usually most commonly as one of the very lower dose patches. That's the most common form. It can be the gel that's also available. These are commercial products. That's what's normally typically used because most conventional doctors would not touch compounded products. So we'll talk about the most commonly used in the medical world. And then we definitely want to talk about, I want to talk about you, what you described about you, going back to that in a minute. But if we talk about the way that hormone receptors work, that is really a critically important point, because the most common use of hormones these days is a little bit of estradiol, usually with a low dose patch, and at night, an oral dose of progesterone. The most common is 100 milligrams. Sometimes people are using 200, but those are the two commercial doses, 100 and 200. So those are the ones that are typically used. And this is, we're talking about, typical conventional medical world, and also a lot of the online companies that are prescribing like by the truckload, and that's their typical regimen. So that's not the way nature ever gives hormones to a woman. There's no time in a woman's lifespan that she would naturally have hormones like that ever, where her ovaries would be making a little bit of estrogen and some progesterone every day, the same dose over and over and over. So in a real healthy, young, reproductive aged woman, and just as a throwing out, this is so important because this goes back, and we'll definitely talk about it another day, the young women who are having messed up periods, like irregular and painful and heavy, The menstrual cycle is a vital sign. That's official. A vital sign, like what's a vital sign? Your blood pressure, your
Mhm.
pulse, your temperature. It's like, so if your menstrual cycle is messed up in any way, that is a sign. Like if you were walking around and you had tachycardia, your pulse was always 120, like that would be a problem. Not only would a cardiologist give you a beta blocker to lower your pulse, but they would also do some testing, like what's going on with your heart. They wouldn't just walk away. They wouldn't, like the doctors like you talked about, who do no testing of these young girls, and they just throw them on birth control pills. So it's important to recognize that the menstrual cycle is a vital sign. So if we look at a normal menstrual cycle, the levels of estradiol, that's estradiol, the estrogen made by the ovaries, and progesterone, not progestin, what's in a birth control pill, but
Right.
that's a made up word, but a real, real progesterone that the ovaries make. They are not static. The same amount comes out of the ovaries a little bit every day. It's dynamic. They're variable. You start when you have your period, that the first day of your period is called day one of a new cycle. At that point, the estradiol level is and the progesterone are very low, very low. And then the progesterone stays extremely low. The estradiol level starts to rise until you're around day 12 in a 28-day cycle, when you have a big spike of estradiol, and that triggers a spike of LH, luteinizing hormone, which then triggers ovulation. And then the ovary starts making more and more progesterone, which goes up into a high amount, and then it plateaus for a while. And then if you're not pregnant, it comes down again, and then you start all over again. The estradiol level, after that giant spike that triggers the LH spike, which triggers ovulation, it dips and then it comes back up to a level higher than what was produced in the first half of the menstrual cycle. So you actually make more estradiol in the second half of the menstrual cycle than in the first half, and you make a lot of progesterone that you don't make at all in the first half of the menstrual cycle. So what is the relationship of these hormones to the receptors? Well, it's very involved and intricate. Estradiol upregulates, so it makes more functional its own receptors, the receptors of progesterone, testosterone, and thyroid. So as your estradiol levels increase, the functionality, the effectiveness of the receptors of testosterone, thyroid, estrogen itself, and progesterone increase.
Mm.
So then when you're mid-cycle, your testosterone, and you have that giant estrogen spike, your testosterone is also at its peak, but it has a very small rhythm in women, but it's actually a little higher. But the testosterone receptors are working optimally at that point, as is your thyroid receptor, for optimization of sex drive, libido, sexual receptiveness of the female to the male, and thyroid function, and progesterone. The receptors for progesterone are working really high at that point, and then you start making all that progesterone, and your estradiol level in the second half is quite high. Now, when the progesterone drops and the estrogen drops, which is the start of the new cycle, that is like a reboot to the receptors. It's like a clean slate, and then they start fresh. When you have progesterone, when progesterone is high in the second half of the menstrual cycle, progesterone down regulates the receptor function of estradiol and of testosterone. So testosterone becomes less effective on its own receptors in the second half of the menstrual cycle, as does estrogen, which is somewhat compensated by the increase in production of estrogen. And the reason estrogen is the receptors are downregulated by progesterone is because part of the essential nature of becoming pregnant is that the growth of the uterine lining has to stop. Okay, so the first half of the menstrual cycle is called, from the uterine perspective, proliferative. The uterine lining is growing or proliferating. And then the second half, when progesterone comes out, is called secretory. It's like flourishing, it's like flowering, but it doesn't grow taller. It just like fills out. It's like a teenage boy who grows like a weed, but he's skinny, and then he stops growing, and then, whoa, where are these muscles coming from, right? So that's like the uterine lining. It just fills out and just becomes blossoming. but it can't keep growing. It can't keep growing. So progesterone downregulates the estrogen receptors. Well,
Mhm.
what happens with this continuous static dosing in menopausal women? It's totally irrational. You're not having proper function of your receptors. So continuous progesterone is continuously downregulating the receptors for testosterone and downregulating the receptors for estradiol. And the estradiol levels are so low that it's not going to have the adequate impact on testosterone receptors or on the thyroid receptors. So nothing is going to be working optimally. And
Mm.
over time, when you have this continuous static dosing, the receptors become less and less receptive, kind of what they call tachyphylaxis, where if like you hear a noise in the background after a while, you just tune it out.
Mhm.
Okay. So that's why some women, after they've been on these static dosing for a while, they suddenly start having a resurgence of night sweats and hot flashes or other menopausal symptoms because nothing is working right and you don't have proper physiologic levels or cycles or rhythms. So your receptors are all really not getting optimized in any way. So this is really a terrible problem. And I'm seeing it just like, prelude to our next conversation in women who've been on birth control pills for many years because the hormones in a birth control pill are not human hormones. They're concocted chemicals. Technically, if you go to the government site on the National Institutes of Health, NIH site, toxicology.gov, you'll see all the ingredients in birth control pills officially listed as endocrine disruptors. Because remember, the fundamental goal of a birth control pill is to block normal function of the ovaries. So they're really actually endocrine disruptors, just like plastic is an endocrine disruptor. I know that sounds weird to say, but I call a spade a spade. Okay, so they are endocrine disruptors and they affect the receptors of hormones differently. And I'm finding, and this has not really been published, I'm seeing it, and that's how most of everything that humanity has acquired as far as new skills and learning is through this amazing thing called observation. Okay, not a placebo-controlled double-blinded study by a big pharma company, but actual observation. Like remember Newton? You're like, oh, the apple fell from the tree. Gravity. So the bottom line is observation. Okay, matters. I have seen so many young women who were put on birth control pills when they were like 14. You can put on women on birth control pills if you call them women, they're kids, after they've been 1 year out. This is official
Yeah.
in the literature. If you've had 12 months since your first period, you can go on birth control pills.
Mm.
So you could be 12. Okay, reality. Okay. So I've seen these young women put on birth control pills at a very early age, and then they decide they want to get pregnant, and now they're like 33. Okay. Oh my goodness. They've been on birth control pills for almost 20 years,
Yeah.
their whole reproductive life. What do you think that does to their receptors? Well, nobody actually knows or seems to care. But what I have seen is that not all of them, some of them like click back, it's very individual, but some of them never click back right. They go off the birth control pills and they all explode with polycystic ovary syndrome that they never had.
Yeah.
Okay. I think being chronically on birth control pills affects the the estrogen and progesterone receptors, that they become malfunctional because of not being properly used or having like the wrong thing stuck in them. And then they become malfunctional. And so you actually are creating PCOS, polycystic ovarian syndrome. And so they all get acne and they're having irregular cycles and infertility. And they're all being told, oh, you have PCOS. Yeah, that's true, but it's drug induced. Okay. So nature didn't do this, the drugs did. And this is not insignificant. It's part of our explosion of PCOS. That's not all. I mean, it's like a whole big deal, but that's part of it is that chronic long-term use of birth control pills impacts the way these hormone receptors work when you get rid of those birth control pill hormones and they're exposed to natural hormones. They don't work right. So this is not a little deal. So, and this matters in menopause in every age. receptors are how hormones work, so it's really critical that we rethink all of our I mean, I've long ago I didn't even think of it in the first place. I think nature knows best. I always say the biggest experiment in we're smarter than nature that failed horribly is ultra processed food.
Yes.
Oh, we can create food that's better than nature's food? I
Yeah.
don't think so. And I think we can create hormone regimens that never exist in nature with rhythms that are non-existent, with doses that are completely incompatible with anything in a woman's life, and we're going to outsmart nature. I do not think so. So I
Yeah.
think most of the hormone therapy that's now being prescribed is crazy. I don't know. I'm trying to be soft here, not too politically incorrect here, but no, it's not. It doesn't make any sense. It's like if you think ultra processed food is good, then you think those hormone regimens are good. If you don't think ultra processed food is good, why would you do a comparable with your hormone regimens? So that is, crazy thinking to think that we can create hormone regimens, or how about hormones that are also not nature's hormones, that
Right.
we're going to make better hormones than nature makes. I don't think so. So, I'm a very simple thinker. I always say that we want to have natural everything as much as we can. And in medicine, when women, because I deal predominantly with women, when they have medical problems, and that's why I call myself integrative. I do not abandon conventional approaches.
Right.
I did surgery. I did many, many, many thousands of hysterectomies, dealing with ovarian tumors and ginormous fibroids. I mean, I can't treat everything with an herb. I mean, realistically, so there's a level of care that you have to have that matches the level of problem, so sometimes you do need surgery. Okay. I did C-sections when I had to, but I had a relatively low C-section rate compared to what's happening today. But sometimes you do it. You save the woman's life and the baby's life. So I'm not against, and sometimes, there are drugs that are really essential in certain situations, but you don't want to start with like the big guns when you could do something that's simpler and safer and more natural. So that's why I have what I call my green medicine, which is herbal medicine, but I still, when I need to, I use pharmaceutical medicine. Somebody shows up in my office with a blood pressure 180 over 120, I'm not going to treat it just with an herb, okay? Because they might have a stroke tomorrow. So, but the reality is that when we can, we want to de escalate in terms of using over the top pharmaceuticals or procedures and try to start with a more natural approach when we can. And everything is tailored to the individual situation. And if you really want to have healthy longevity, you have to have all those pieces of your puzzle put together, which includes all the lifestyle pieces, but you need hormones that are compatible with being healthy, which means hormones compatible with the way the female body evolved to be, which is not the current regimens that are being used.